All right, so today we're going to talk about what we need to know about cardiovascular calcifications. So we'll start with this case here. What do we have to say about this?
Pericardial calcification.
Okay, and usually pericardial calcification is better seen on which view?
Lateral?
Yeah, often it's better seen on the lateral view. So you can see it here, this pericardial calcification. What is the significance of pericardial calcification? So what? There's pericardial calcification. So what? What's the significance of this? Yeah, the association with constrictive pericarditis, okay? So, and then on CT, we can see it a little bit easier. So here's the pericardial calcification there, okay? And then here it is on this reformatted short axis view. So on the lateral view, you can see it's usually easier seen more anteriorly. So in this particular patient, do you think this pericardial calcification is physiologically significant? Yes or no?
Yes.
Why? So it looks like there's some deviation of the interventricular septum. Anything else?
Reflex IVC.
Yeah, so the IVC is dilated, indicating that there's some elevated pressures on the right side. What else is dilated? What?
The azygous dilated?
I can't hear you.
The
What?
azygous vein?
Where's the azygous vein?
That's below the...
What is this guy? What is this guy?
coronary sinus.
That's the coronary sinus, right? So the coronary sinus is dilated. So there's evidence that there's increased filling pressures here on the right side, so that you would suspect then that this pericardial calcification is significant, and this patient might have constrictive pericarditis. So these are other signs that we would look for. Even on a non-cardiac gated CT scan, you might be able to make some of these judgments, right? And then here on this volume rendered view, you can see that this pericardial calcification is really much more extensive than what you would imagine just looking at a series of axial views, okay? So there are various causes for pericardial calcification. It can be post-infectious, like from viral infections, rheumatic pericarditis. Tuberculosis worldwide is a very common cause of pericardial calcification and a common cause of constrictive pericarditis. You can see it after pyogenic infections. In this country, we can also see constrictive pericarditis after surgery. So in this country, post-surgical is a common cause of constrictive pericarditis. So 50 to 70% with pericardial calcifications will have constrictive pericarditis, and 90% with constrictive pericarditis will have pericardial calcification. So it's an important finding. If you note it, then you might want to recommend echocardiography for that patient. So the sites of calcification, right and anterior, greater than left, AV grooves and diaphragmatic border. Usually the left atrium is spared, lack of pericardium. The left ventricle also, because of the motion of the left ventricle, can prevent calcifications from building up in the overlying pericardium. So thin linear calcifications like this, often this is better seen on the lateral view. So on the lateral view, you need to be able to notice this if we see that. And this type of calcification can be associated with viral and uremic pericarditis. Thicker calcification, like you see in this example, can be associated with TB pericarditis. And so here's the CT scan on that patient with the thicker calcifications here, okay? And then you might, patients can also have loculated collections in the pericardium, especially after infections that can go on to calcify. So we might see that also in some unusual cases. And that also can impair cardiac function. See the dilated IVC in this case. What do we think of this case?
Myocardial calcification.
So where's the calcification here?
Left ventricle.
What part of the left ventricle?
Interior wall.
And
Apex.
apex, right. So what's the significance? What's the significance of this?
Post-infarct myocardial infarction.
So when we see myocardial calcification, then it's usually associated with prior myocardial infarction, and the most common location to see myocardial calcification is over the apex of the ventricle, right? So this indicates that there's been a remote infarct, so that gives the tissue time to actually go on and calcify. So it occurs in about 8% of patients after myocardial infarction. The most common sites, anterolateral or apical region of the left ventricle. Now, this calcification can occur in the wall of a true aneurysm. Do true aneurysms rupture?
No.
No, true aneurysms do not rupture. It's the false aneurysms that you have to worry about. False aneurysms rupture. The false aneurysms calcify. Do false aneurysms calcify, yes or no?
No.
No, no. So calcification is usually a sign of a true aneurysm. So over the apex of the left ventricle, again, this is often easier to see on the lateral view. Very easy diagnosis on CT. We can see the calcification over the apex of the ventricle, okay? So that tells you that this patient has had a prior myocardial infarction. So usually preceded by a sizable infarct, anterolateral or apical left ventricle, so it's commonly caused by infarction in the distribution of the LAD. So it's often calcification in the wall of a true aneurysm, and it takes years for this to develop, so that implies that the survival has been greater than 6 years. For whatever reason, it's more common in males than females. And most patients have right coronary artery dominance, as in most cases, as that favors longer survival after LAD obstruction. So here's another example of myocardial calcification, better seen on the lateral view. In this case, though, you can see most of it is along the interventricular septum. But again, that's in the course of the left anterior descending coronary artery distribution. What do we think of this case?
Aortic valve is calcified.
Okay, so here again, calcification is better seen on the lateral view. Remember I told you that if you're looking at a chest radiograph and the finding is not obvious, that you should develop a list of places to look for abnormalities if you're looking at a chest radiograph. Some of the things we talked about, what were some of the things that we talked about that you might look for if the finding is not obvious? Where do you look?
For like rib notching.
Look for rib notching, but more important than rib notching is what? If the diagnosis you're going for is what? Well, we're rib notching, what diagnosis are you going for? Coarctation. So more important than the rib notching, you would look for what if you're going for coarctation? The figure 3 sign, right? So you look for undulation of the aorta. So that's one thing that you'd want to put on your list, right? Another thing, also make sure that you look in the AP window, right? You can have bulging out from the, not in this case, but you can have lymphadenopathy in the AP window that might not be, that you might not notice right away. But aortic valve calcification, pericardial calcification, like we saw in the prior cases, more obvious on the lateral view. Start to build up a list of things that if the chest X-ray looks normal, where are you going to look? So that's going to be very useful when you're taking exams, right? So aortic valve calcification, very easy to miss because it's better seen on the lateral view, right? So how do you know that's the aortic valve? What's the location? What's the locational cue that tells you that's the aortic valve? How do we localize the aortic valve? Yeah, so on the lateral view, we draw a line from the airway here, the bifurcation of the airway down to the anterior cardiophrenic angle. We look in the middle of the heart, and if there's calcification anterior to that, it's usually the aortic valve. If you happen to notice calcification posterior to that, then that would be the mitral valve. Although it's very, very unusual to actually see mitral valve calcification on the plain film. So if we see calcification like this on the plain film, it's much more likely to be aortic valve calcification than it will be mitral valve calcification, right? So that's aortic valve calcification. The significance of seeing aortic valve calcification on the plain film is what? What? It always means aortic stenosis, all right? So if you see, not true on CT, but if you see aortic valve calcification on the plain film, it always means aortic valvular stenosis. So that means if you happen to notice it, you want to recommend echocardiography if that hasn't been diagnosed already. So calcification within a valve on the plain film always indicates valvular stenosis. The amount of calcification correlates with the amount of stenosis. The most common valve to calcify is the aortic valve. Again, most commonly from atherosclerotic degeneration of a tricuspid valve. The second most common cause is the bicuspid aortic valve. And then we might also see aortic valve stenosis from rheumatic heart disease, although in those patients, usually the mitral valve is also involved physiologically. So for mitral valve calcification, pretty much the most common cause of that is going to be rheumatic heart disease. So especially with bicuspid aortic valves, this is the most common congenital cardiac malformation. Because one cusp tends to be larger than the other, that results in damage to the valve, fibrosis, calcification, and then eventually aortic stenosis. So for a bicuspid aortic valve, the calcifications can be detected at an earlier age, and sometimes the configuration of the calcification tells you the morphology of the valve. So this is a bicuspid pattern of calcification. You can see the raphe here, the bicuspid valve is actually calcified. So that tells you that that is a bicuspid aortic valve. So here's a close-up of this, okay? So this pattern of calcification is a bicuspid pattern of aortic valve calcification, if we happen to see that. So bicuspid patterns, there's a mushroom pattern where you can see the raphe calcify. Here's another example of a bicuspid pattern of aortic valve calcification. All right. You can have nodular calcifications also on the aortic valve, dilatation of the ascending aorta, poststenotic dilatation of the ascending aorta, another clue that you're dealing with aortic valvular stenosis. This is non-gated cardiac CT. Sometimes you can make the diagnosis on a routine non-gated cardiac CT scan. Right? So here we happen to catch the aortic valve when it's open, and we can say, well, that's a bicuspid aortic valve, and it's calcified. Okay? And then here on this coronal reconstruction, we can see calcifications of the aortic valve. This patient did have aortic valvular stenosis, right? So in patients who show up in the emergency room with chest pain, etc., especially if they have signs of failure, we do CT scans for pulmonary embolism. It's important to look at the aortic valve. You may pick up a case of aortic valvular stenosis on those kinds of cases. So here's an example of a bicuspid pattern of calcification here on this close-up, right? So that tells you that even though this valve is closed, this patient has a bicuspid aortic valve. So rheumatic heart disease is another cause of aortic valve calcification, although this is usually associated with mitral valve disease. Here, the age of calcification is somewhat older. These patients can have nodular calcification, dilatation of the ascending aorta. They might have signs of rheumatic mitral valve disease. What are those signs on the plain film?
Left atrial dilatation.
Yeah, sure. Left atrial dilatation, right? That tells you there's a mitral valve problem. Pulmonary venous congestion, right? Because of elevated left atrial pressures, causing pulmonary venous congestion in patients with mitral valve disease and mitral stenosis. So those are other things that you can look for. A later complication of rheumatic heart disease and mitral stenosis is what? How does it affect the pulmonary artery pressure? Pulmonary artery hypertension. So as a later complication of rheumatic heart disease is pulmonary artery hypertension. So on the plain film, you might notice, well, what's the finding? Yeah, a centralized pattern of big pulmonary arteries. So those are all findings that would support the diagnosis of rheumatic heart disease. So here's a patient who has both calcification of the aortic valve and the mitral valve here, right? So this patient had rheumatic heart disease that affected both the mitral valve and the aortic valve. You can see that there is dilatation both of the left atrium and the left ventricle in this patient, okay? Right heart is also dilated in this patient. Big pulmonary artery in this patient. So this patient's also developed a complication of pulmonary hypertension. So atherosclerotic degeneration of the aortic valve, of a tricuspid aortic valve, is the most common cause of aortic valvular stenosis. So these patients develop calcification somewhat later. So they can have nodular calcification, they can have dilatation of the aorta, poststenotic dilatation. The heart size is usually normal. With decompensation, though, that's when you start to get left ventricular dilatation in these cases. So this is a tricuspid pattern of calcification, 3 nodular calcifications here, telling you that's a tricuspid pattern of calcification of the aortic valve. Here on CT, tricuspid pattern of calcification, 3 nodules of calcification here on the aortic valve. And then here's a nice correlate with the intraop of Kieran's. So you see these calcifications, a tricuspid pattern of calcifications here, and here's the correlate intraop photograph to show you what you're looking at. And this patient, of course, had thickening and aortic valve stenosis. So it's important when you're looking at CTs to notice aortic valve calcification, even on your routine CT scans, because the more extensive the calcification, the higher the probability of aortic valve stenosis and the more severe the aortic valve stenosis. So the more calcifications that you see on the aortic valve, that tends to correlate with more severe aortic valvular stenosis. So if we see calcifications on the aortic valve, we want to bring that up in our report. And if the patient hasn't already had, we want to recommend echocardiography to evaluate for aortic valvular stenosis. Okay. What do we think of this case?
Pulmonary stenosis.
Why?
The asymmetric dilatation of the left.
So you notice there's dilatation of the main and the left pulmonary artery. The right pulmonary artery is normal, right? So that configuration is associated with pulmonic valvular stenosis. Is there another finding here that goes with pulmonic valvular stenosis?
Starting of the right pulmonary artery.
Well, that's what he said. Now he's taking a bow because he said it. Was there another finding? It goes with pulmonic valvular stenosis here. It's quite an unusual finding, actually. Calcification of what? This is the pulmonic valve here. There's calcification of the pulmonic valve. You almost never see that, right? We commonly see calcification of the aortic valve, but calcification of the pulmonic valve is extremely rare. But calcification of a valve is an indication that my patient might have stenosis. So this is someone with pulmonary valvular stenosis. Okay, it's unusual to actually see calcification within the pulmonic valve, even in patients with pulmonary valvular stenosis. Okay. What's calcified here?
Mitral valve annulus.
Well, no. You're close.
Mitral valve.
It's actually the mitral valve. Right? So the annulus is a little bit more peripheral. So here there's calcification of the mitral valve itself. Right? Now CT is very sensitive to calcification. So as opposed to plain film, right? On the plain film, if we see aortic valve calcification or if we see mitral valve calcification, it always means the patient has stenosis. Not always true on CT. There's a case of small amount of calcification there of the mitral valve. Now, mitral valve calcification on CT, especially on a post-contrast CT, this can be missed very easily, right? Especially when you have contrast in here, right? So you can miss the fact that, well, there's calcification here of the mitral valve, right? So it's important whenever you're looking at CT scans to also look at wide windows. So width of 800, level of 100. So if you're, I always recommend when you're looking at a post-contrast CT, especially if the contrast is very dense, to also look at the heart and the blood vessels in wider windows. And then you can differentiate calcification from contrast very easily. So here you can see the calcification of the mitral valve. And then here on the reformatted short axis view, again, this is a non-gated cardiac CT. I mean, it's not a cardiac CT at all. This is a non-gated chest CT. This is a routine chest CT, but you can make these findings on routine chest CTs. So here's a short axis reconstruction of the mitral valve, looking at it on FOSS, and you can see that there are calcifications here of the mitral valve. Here's a two-chamber view, calcifications of the mitral valve. So you can make these findings on routine chest CT scans. So calcification of the mitral valve, the most common cause of that is rheumatic heart disease. And also mitral stenosis. Of course, the most common cause of that is rheumatic heart disease. So we can have nodular and amorphous calcification. If there is stenosis, you will see enlargement of the left atrium, especially the left atrial appendage, signs of obstruction of blood flow through the mitral valve, pulmonary venous hypertension, cephalization, interstitial edema. In later stages, you will have signs of secondary pulmonary artery hypertension and large central pulmonary arteries in the long-standing cases. So here's an example of somebody with calcification here in the region of the mitral valve on the lateral view. Left atrium is enlarged here. You can see how it's pushing the esophagus back. This patient also has some enlargement of the main pulmonary artery and the left atrial appendage. With left atrial appendage enlargement, you would expect main pulmonary artery enlargement here because of pulmonary hypertension. So what do we notice in this case? By the way, again, this is a non-gated CT. This is a routine chest CT. There is aortic valve calcification, yes, so we see that. And you see calcification anywhere else? Yes, there's mitral valve calcification. So this patient has both mitral valve calcification and aortic valve calcification. How might we account for that? What would cause that? Rheumatic heart disease, yes. And also when we look at the cardiac chambers here, what do we notice about? There's dilatation of the left atrium. So you would suspect the patient has?
Rheumatic heart disease.
And causing what? Mitral stenosis, right? So you suspect the patient has mitral stenosis. And also with this amount of aortic calcification, you might wonder about aortic stenosis also, aortic valvular stenosis. So this was a patient with rheumatic heart disease with mitral valve stenosis and aortic valve stenosis, and you can at least suggest the findings on a routine chest CT scan. Okay? Yeah.
What is the hyperdensity in the right atrium, right where your mouse is?
There's a
it's a
pacemaker.
catheter.
Yeah, or a catheter, right? But there's something in there. Looks like maybe a pacemaker lead. Now, when we reformat, you can see the calcification of the aortic valve. You can see the calcification of the mitral valve. Here's a reformat going right through the aortic valve itself in the plane of the aortic valve, and you can see the extent of calcifications. Okay. Jared, what's calcified here?
Mitral valve.
There you go. Right. So here we have calcification of the mitral valve annulus, right? So that's not quite the valve itself, it's the fibrous insertion of the valve, so it's more peripheral than that. So it's at the undersurface of the valve, right? So the mitral valve calcification, so we'll look for that at the level of the valve. When you get just below that, that's when you start to see the mitral annulus calcification. So what's the usual significance of mitral annulus calcification? Nothing. So usually it's an incidental finding. You don't want to mistake it for something bad. There are instances where it can be associated with pathology, and we'll talk about that. So this is mitral annulus calcification. It's at the insertion of the valve. On the plain film, it has a characteristic reverse C-shaped appearance, right? So this is the annulus, the fibrous insertion of the valve, and it's demonstrated very nicely, again, non-gated CT, demonstrated very nicely on a short axis reconstruction. You can see this is the insertion, the fibrous ring, the insertion of the mitral valve, and that's what is calcified here. That's mitral annulus calcification, right? So here it is on the plain film. That's what it looks like, this reverse C-shaped calcification. So this is not coronary artery calcification, this is mitral annulus calcification. So usually women, elderly women, usually involves the annulus of the posterior leaflet, usually not clinically important, but there are some cases where massive calcification might result in mitral insufficiency or atrial fibrillation or conduction defects, but that's unusual. In most cases, mitral annulus calcification is just an incidental finding, right? So that reverse C-shaped calcification, sometimes O-shaped if the anterior leaflet's also involved, is what we see with mitral annulus calcification. All right, so what's going on here? So this patient had echocardiography where they questioned the mass. There it is there on MR. There it is there on CT. What is this?
Caseous degeneration.
Yeah, so this is caseous degeneration of the mitral valve annulus, right? Sometimes it can have areas of low attenuation, fatty attenuation in here, and this can be mistaken for a mass on echocardiography because of the way it kind of bulges out into the wall, all right? But it's an easy diagnosis on imaging to say that, well, that's just caseous degeneration of the mitral valve annulus. It's right there in the region of the mitral valve annulus. It can have regions of lower attenuation because of some fatty kind of attenuation that gets in there from necrosis. And so there, on histology, there's a mixture of cholesterol, which accounts for that lower attenuation, calcium fatty acids, yielding a pasty acellular texture, a core of liquefaction necrosis. Right? So that's what happens there at the mitral valve annulus. So that's the characteristic location. We don't want to mistake this for a mass or anything bad. We don't need to do anything about this. So that's just caseous degeneration of the mitral valve annulus. Okay? What is calcified here?
Pulmonic valve.
Not the pulmonic valve, no. What is this? You said, yeah, this is the left atrium. This is the wall of the left atrium that's calcified. So what is the significance of calcification of the wall of the left atrium? Why does that matter? What does that mean?
Increased pressure.
Okay, what does this tell us about the patient? This is associated with what? What disease causes this? Yeah, rheumatic heart disease. So it's strongly associated with rheumatic heart disease. There's one other thing it tells us about the patient. Does the patient have an arrhythmia? What arrhythmia is this associated with? AFib, right. So this is associated with atrial fibrillation and strongly associated with rheumatic heart disease. So calcification of left atrial wall, usually secondary endocarditis for rheumatic heart disease. Patients can have long-standing CHF, mitral stenosis, atrial fibrillation, and of course, because of the atrial fibrillation, they might have mural thrombi. They might develop complications of systemic and pulmonary embolus. Right? So patients usually also have CHF and atrial fibrillation. That's a setup for developing mural thrombi to cause systemic emboli, pulmonary emboli. Possible surgical complications, and if they go in to try to fix their mitral valve disease. The mural thrombi can be dislodged during surgery. Of course, that can cause cerebral emboli. Also, because the left atrial wall is very stiff, another complication might be hemorrhage during surgery because of the difficulty controlling that from the stiffness of the atrial wall. Right? So we can see this on CT. This patient's already had a mitral valve replacement. But you can see the left atrium is dilated, but we can also see there is calcification here along the wall of the left atrium. So that is strongly associated with rheumatic heart disease. We see that. Aortic calcification of the aorta itself, of course, we know that occurs from atherosclerosis, usually the arch and the distal aorta, ascending aorta spared. If we see it in younger patients, hyperlipidemia, diabetes, predisposed to calcification. We all know what aortic with calcification of the aorta looks like. Sometimes with syphilis, you can have diffuse extensive calcification, especially involving the ascending aorta. Those patients can also develop ascending aortic aneurysms. Right? So we're all familiar with calcification of the aorta. Syphilitic aortitis, they can develop aneurysms of the ascending aorta and aortic insufficiency. Anything that gives you aneurysms or dilatation of the ascending aorta can result in aortic insufficiency. And angina, in these cases, if the ostia of the coronary arteries are also involved. What do we think of this?
Pulmonary artery calcification.
Yeah, so there's pulmonary artery calcification. The significance of pulmonary artery calcification is what?
Prior PE.
What's that?
Prior PE.
No. Pulmonary hypertension, right? Clots can calcify. So chronic pulmonary embolism can calcify. So if you see peripheral filling defects that are calcified, then you're dealing with chronic PE, right? But calcification along the wall of the pulmonary artery itself pretty much always means pulmonary hypertension, okay? And then in this case, you can see big central pulmonary arteries. So calcification of the pulmonary artery, pulmonary hypertension, right? What's calcified here? First of all, does everybody see the calcification?
Ligamentum.
Yeah. So that is the ligamentum arteriosus here. That's calcified. Okay. This is extremely common. If you look for this, you will see this. So this is not a calcified lymph node. This occurs in the region of the ligamentum arteriosum between the proximal descending thoracic aorta and the pulmonary artery there, especially the left pulmonary artery. Look for this on your CT scans. You will see it. Calcification of the ligamentum arteriosum. Very common. All right? There it is on a coronal reconstruction. Here it is on the sagittal. You can see the proximal descending aorta to the pulmonary artery. That's calcification of ligamentum arteriosum. Here's a very nice example where you can actually see it, the whole line of the ligamentum arteriosum that is calcified. Right? So it indicates a closed ductus. Right? So we know in embryology, we have a patent ductus arteriosus. When it closes, you get a ligamentum arteriosum. And when it closes, it calcifies, like that, dot-like or linear. Okay? So here again, calcification of the ligamentum arteriosum. Now, something else that's been noted, although I don't have a good explanation for it, is if you look at the descending thoracic aorta, you'll often find calcification along the wall of the descending thoracic aorta, right next to the insertion of this. Don't know why that occurs, but you'll notice there are patients that will have calcifications all over the aorta, but then you'll notice patients that have very little calcification, but they have calcification right there. Why does that occur? I don't know. So, looking at the plain film here, what's abnormal? So starting with that film at the left, we want to start with pulmonary vascularity, right? So is that pulmonary vascularity normal? What's wrong with it?
More.
Yeah, so there's increased pulmonary vascularity, right? So you have increased pulmonary vascularity here. Is there any particular vessel that's dilated?
The left main pulmonary artery.
So the main pulmonary artery here is dilated, right? That bump is the main pulmonary artery. Do you think the right pulmonary artery is big?
Yes.
Yes. Yeah, you have all of this. You can see all these vessels going all the way up into the lungs, and they're dilated, right? So what do we think this patient has as far as the pulmonary vascularity goes? What are we thinking about here? With big centralized pulmonary arteries, we're thinking, right? So maybe this patient has pulmonary hypertension. Okay. Now, later on we'll go through a more detailed discussion of causes of pulmonary hypertension. Okay. What do we think of the close-up? Do we notice any calcifications? Remember, this talk is on calcifications. So in that close-up view, do we see an abnormal calcification?
Patent ductus.
So where's the calcification?
At the ductus.
Well, anatomically, if you're describing the plain film to me over the phone, you would say there's Dr. Malgin, there's calcification along the AP window. And in a patient with pulmonary hypertension and big central pulmonary arteries, we have calcification in that region. You suspect the patient has patent ductus arteriosus. So the patent ductus arteriosus causes what? Left to right shunt. And that results in increased pulmonary blood flow. And then later on, the patient develops pulmonary hypertension. And if it gets really severe as a later complication, the patient can develop Eisenmengers, right? So what's Eisenmengers?
Eisenmenger syndrome is a reversal of the shunt.
Yeah, so what started out as a left to right shunt actually starts to reverse right to left because the pulmonary pressures become so high. Okay? So on the CT, we have a very large main pulmonary artery here, okay? And we can see calcification of the ductus arteriosus. This is a patent ductus arteriosus. Very large. You can see the connection from the aorta to the pulmonary artery here. Here on the sagittal reconstruction, it's laid out very nicely. There's the communication between the descending aorta and the pulmonary artery. And here's a nice volume rendered view. Aorta, pulmonary artery, big pulmonary artery, patent ductus arteriosus, right? So this calcification along the wall of the patent ductus arteriosus. So remember, calcification of the ligamentum arteriosum is not going to give you pulmonary hypertension, right? Because there it's closed. But if we have pulmonary hypertension, or it looks like we have increased pulmonary blood flow in a patient, we see calcification along the AP window on a chest radiograph, might bring up the possibility of it being ductus arteriosus, right? Calcification here in the region of the AP window in somebody with a very large central pulmonary arteries. So on CT, we can see the calcification, but often, well, you can also see the communication between the aorta and the pulmonary artery on CT. All right, so let's move on now to coronary artery calcification. So the most common location on the plain film to see coronary artery calcification is called the coronary artery triangle. Here it's the left upper corner of the heart, right over there. So that's where we can see it on the frontal view. You can also see it on the lateral views. You see coronary artery calcification there. Laterally, this patient also looks like we have put in some stents. So the only cause for this is atherosclerosis, right? So it indicates that there is coronary artery disease. Doesn't necessarily mean that there's obstruction. Doesn't mean that there's a significant obstruction, but the patient does have atherosclerotic coronary artery disease. It's a surrogate measure. The amount of calcification is a surrogate measure for the number of soft plaques. Remember, it's the soft plaques that are important because those are the vulnerable plaques. Those are the ones that can rupture and can cause myocardial infarction. Now, there are numbers for the sensitivity and specificity for detecting coronary artery calcification, fluoroscopy versus electron beam CT. So in the old days, the only way you could do cardiac CT was with electron beam CT before multi-detector CT. But of course, CT is very sensitive for coronary artery calcification. A lot of the literature on coronary artery calcification was done using electron beam CT. So remember that to be able to minimize cardiac motion, you need to be able to scan very quickly. You need very good temporal resolution. So now we can do it with the gantry rotating around pretty quickly. But before that was possible, they had to rotate the X-ray beam and they would deflect the X-ray beam using magnetic fields with electron beam CT. So they fire the beam at a target and then using magnetic fields, they would direct that beam around the patient in order to go around the patient fast enough to get your temporal resolution down to between 50 and 100 milliseconds, right? But now this is no longer done, but a lot of the literature on coronary artery calcification was acquired using electron beam CT. So now we do it with multi-detector CT, now we do it with cardiac gating. It's a very easy test to do. We do a non-contrast CT with cardiac gating, and actually, it's pretty brainless. You just find the coronary calcifications and you put circles around, where the calcifications are, and you label what vessel, and then the software does everything else for you. Right? What kind of cardiac gating is used for coronary calcium scoring? Well, we have two. We have
Prospective.
prospective. Why prospective?
Reduce dose.
Reduced dose, right. We're just looking at coronary calcium here. There's no reason to do a full-blown retrospective gated study, right? So to maintain the lower dose, we do it with prospective gating. So remember, with prospective gating, we only scan in this short portion of the cardiac cycle, and we reconstruct our images at that portion of the cardiac cycle, so that's where we do our gating. That's where we scan. During diastole, when there's a decreased amount of motion of the heart where the coronary arteries are, okay? One other thing about technique, you will notice that when we do cardiac CT, when we do coronary artery CT, and we look at the images, right? What's the slice thickness of those images? Coronary artery CT? 0.625, right? So when you're doing coronary artery CT, we look at it at the minimum slice thickness we can obtain, which is 0.625 millimeters on our particular scanners, right? When we're doing coronary artery CT, coronary CTA, right? When we're doing coronary calcium scoring, what's the slice thickness of the images you're looking at?
2.5.
What?
2.5.
Yes, it's 2.5. Why? Why? Why is it 2.5? It's always 2.5. Why? I mean, we can get 1.25, we can get 0.5, we can, 0.625, right? 0.625. You get 1 centimeter, you can do whatever you want. Why is it always 2.5? What are you doing on those images? How? What did I say? It's brainless, right? What do?
Circling.
You're circling the vessels. The software, though, is taking your measurements. And the most common scoring system that is used is the Agatston scoring system, right? Remember I said that a lot of the literature on coronary artery calcification was done using the electron beam scanners, the older scanners. And a lot of and that Agatston scoring system has been around since the very beginning. And a lot of the data that we have on prognosis and the significance was done using that scoring system, which uses 2.5 millimeter thick slices. That's why, given all the techniques we have, we're still looking at 2.5 millimeter thick images when we're doing coronary artery calcification scoring. Okay? Now, retrospective gating, of course, the X-ray tube is on throughout the cardiac cycle, right? But that increases the dose, and there's no reason to do that if all we're doing is looking for coronary calcifications. So it's very brainless. We do it with prospective gating, put your little markers around where the calcium is, label the vessels so the software knows what vessels you're looking at, and then it spits out a score. The Agatston scoring system. So this is traditionally the scoring system that's been used. It's been around, God, for over 30 years, I guess, and we're still using it. You don't have to memorize this, okay? I'm not interested in you memorizing this, but I do want you to know that it is a weighted scoring system, right? So depending on the attenuation of the particular pixel that is being measured, right? It's multiplied. So if it's this attenuation multiplied by a factor of 1, if it's between 200 and 300, it's multiplied by a factor of 2, between 301 and 400, multiplied by. So it's a weighted scoring system depending on the attenuation that are being measured, okay? And it's the sum of all of this that the algorithm then spits out to you as a calcium score for that artery, and then it adds it all up to give you an overall calcium score. So problems with the Agatston scoring system, there's up to 20% variability. You can scan the patient twice in a row, but it's a weighted scoring system. There's, just a little bit of misregistration between the two scans, partial volume averaging, up to 20% variability, same patient. Okay? Volume scoring is more reproducible if you actually just take the volume of the calcifications, but again, it's the Agatston system that has been most commonly used. And same thing with mass scoring, where you can measure them in milligrams, how much calcium is there. All of this, the software will give you. The software will give you all of these numbers, but people still use the Agatston scoring system for determining how to manage the patient. So we trace the calcifications. We tell the software what vessel we're looking at. Here we're looking at LAD. Here we're looking at the circumflex coronary artery. And then the software does the rest for you. So using the Agatston scoring system, which is here, it'll also give you the mass and the volume of the calcifications, but it's this system here that is used, and it will tell you what's the score along each vessel, and then it will give you a total score. Okay? And then we can look at this for this particular patient, who I guess was around 62 years old. This patient had a calcium score of 504. This placed the patient in the 90th percentile rank. 10% of females at that age will have a higher calcium. And this software tells you all of this, okay, after you've pointed out where the calcifications are. What's important about the numbers itself? So a calcium score of 0, excellent, right? That is great. So the 10-year event rate is extremely low. It's positive even if your calcium score is 1, right? That's a positive study, even if your calcium score is 1. But the risk is still low, 4%. Intermediate between 101 and 400, greater than 400 is high risk, and of course greater than 1,000 is very high risk. Okay? So that's what you need to know about the actual numbers themselves and the risk categorization. The significance of a score greater than 0, it means there is coronary atherosclerotic plaque. The greater the amount of calcium, the greater the likelihood of occlusive coronary artery disease. This is important. There is not a one-to-one relationship. And where you have the most extensive calcification is not necessarily where you have the most degree of stenosis. So it's a marker that the patient is at increased risk for stenosis, but it doesn't necessarily tell you where the stenosis is. So the total amount of calcium correlates with the total amount of atherosclerotic plaque, although the true plaque burden is underestimated. Only 20% of plaque volume is calcium, right? The rest of it is non-calcified. High calcium score means a moderate to high risk of cardiovascular event within the next 2 to 5 years. It is a stronger independent predictor than all other conventional risk factors. So here you can see what happens as the survival, as the calcium score gets higher and higher. Calcium score of 0, you are immortal. Calcium score of 1,000, very bad news. Okay? So it just shows you that, you know, if I'm writing life insurance policies for a patient, I'm sending them for a calcium score, and that's going to determine the premium. So it's the tip of the iceberg, the calcium. Calcium is only 20% of the plaque volume, right? The rest of it is non-calcified, so we don't see the rest of it on non-contrast CT.
Dr. Mulder?
Yes.
This may be like a primary care question, but what type of patients did those?
We're going to talk about this.
Okay, perfect.
Calcified plaque, and here's one of the issues with this. Calcified plaque tends to be chronic plaque. So there may be a fixed stenosis there, it might be, where you have this chronic calcified plaque. The problem though, the patients who have myocardial infarctions, they have vulnerable soft plaque. Soft plaque is not necessarily calcified, right? So it's when this plaque ruptures, and it's not causing significant stenosis of the vessel. When this plaque ruptures, you get acute thrombosis, and that causes the myocardial infarction. So soft plaque is the problem, not necessarily the calcified plaque. But the extent of calcified plaque is a marker for how much underlying plaque you have overall. So it's this non-calcified plaque that's really the problem, but you can only see that if you do a full-blown coronary artery CT. Okay? The bad news, at age 65 for men and 75 for women, the prevalence of coronary artery calcification is greater than 90%. They all have calcium. What do we do with that? Specificity for coronary artery calcification for predicting coronary artery disease decreases with age because it's just more common as patients get older. We've said that the Agatston scoring system, there's suboptimal reproducibility of the calcium score, so you can't just follow these patients from year to year and say, okay, what's happening to the coronary calcium? Is the treatment working? I don't know. So what about older asymptomatic individuals, right? So they're going to have coronary calcium. What is the prognostic significance of coronary calcium in older asymptomatic individuals? We don't quite know the answer to that. The absence of any coronary artery calcification, however, does not exclude the presence of atherosclerotic disease. It is still possible for patients to have soft plaques and to have no calcium. That is why for a symptomatic patient, a calcium score of 0 is not 100% reliable, right? So calcium score of 0 is extremely reliable in asymptomatic patients, but in a symptomatic patient, a calcium score of 0, they might still have obstructive coronary artery disease. There is no correlation between calciumeria and luminaria due to remodeling. What do we mean by that? We mean that when these patients develop calcification of the plaques, it tends to grow away from the lumen, right? Which means that it doesn't cause, in many cases, significant stenosis of the lumen. So you can have heavily calcified plaque with not much encroachment on the lumen. Okay? So the location of the heaviest calcifications are not site-specific for the locations of stenosis. So coronary calcification is an indicator of overall atherosclerotic burden, but it does not correlate with site-specific stenosis, okay? In patients who have a first myocardial infarction, 22% of culprit arteries had no calcification. So these culprit vessels, 22% of the time, the culprit, the lesion that is causing the infarction, 22% of the time is not calcified, all right? And 41% only have mild calcification. All right, now what does this have to do with, what does this mean for prognosis? Well, there's the Framingham risk model here, and all of this is available, you just plug in all of these numbers, and this is what insurance companies use to determine the premium, right? Just plug in all of these numbers, and it will spit out a 10-year risk for myocardial infarction or coronary death. Low risk, medium risk, high risk, okay? And this is the data that you need. So for population, this is pretty reliable if you're dealing with a large number of people in the population. Now, if we can add to this, if you have it, you can add to it the coronary calcium score, right? So this is available, and you put in all these numbers and you add the coronary calcium score, and now you get an estimate of risk that is even more reliable, okay? So here we have an 80-year-old man with a 0 calcium score, without coronary calcium. I'm sorry. If you have an 80-year-old man and you haven't scored the calcium, right, just putting in their risk factors, their 10-year risk is 12.7%. If we put in a calcium score of 0, the 10-year risk drops to 3.6%. Okay? So this does affect management. It does affect, how you're looking at risk in these patients. So the availability of the calcium score changes the therapy in terms of what you would offer these patients. And this is how it can be used in practice. So let's say you have a patient who you've taken their risk factors, borderline risk, okay? Calcium score of 0, statin therapy is not recommended. Calcium score greater than 0, that means 1. Consider statin therapy. Intermediate risk, where your risk is 7.5 to 20%. Calcium score of 0, statin therapy not recommended. Calcium score greater than 0, statin therapy recommended. So the calcium score changes management when we're in this borderline and intermediate risk group. So these are the patients that might benefit from coronary calcium scoring. So if after assessment of risk, the treatment is still uncertain, you can consider calcium score. So patients with an intermediate risk, if their calcium score is high, they're high risk now. They jump from intermediate to high risk. Diabetic patients also may benefit from coronary calcium scoring because they develop calcium at an earlier age. Calcium score probably not reasonable if the 10-year risk is less than 10%, so that's the low risk group. But if you're in the intermediate risk group, the calcium score does change management, and that's how it can be used. Right? So again, just a reminder of how we use calcium score and how that relates to your overall risk, okay, your 10-year risk. So calcium score here and your risk, this is pretty much what we've already gone over. 400 puts you at very high risk, of course, greater than 400. The value of a calcium score of 0 in an asymptomatic patient. This is found in 40 to 50% of low to intermediate risk groups. So that intermediate risk group, about almost 50% of them might have a calcium score of 0. That means they have a very low risk of atherosclerotic coronary artery disease, very low mortality from cardiac disease that is guaranteed for 15 years. All right? So if you look here at the mortality from coronary heart disease in these patients, this group, 66,000 patients. Right? 0.1. For cardiovascular disease mortality, 0.3. Even cancer mortality, all-cause mortality, extremely low for patients who have a calcium score of 0. Right? So very low mortality, especially from cardiac disease in this group of patients. The calcium score is the easiest way to identify persons in need of statins compared to risk factor guidelines. That's the way it can be used to manage their therapy. All right? So again, getting back to how reliable, so far we're talking about calcium scoring in asymptomatic patients. How reliable is a calcium score of 0 in a symptomatic patient? You have to be careful. So in some studies that have been done, small percentage of these patients will have underlying significant obstructive disease. Okay? So a calcium score of 0 in a symptomatic patient is not necessarily reliable. Comparing calcium score to coronary CTA, there's no comparison. When we do coronary CTA, of course, we also get a calcium score anyway, right? But in terms of sensitivity, specificity, median positive predictive value, but here you're looking for obstructive coronary artery disease, right? And of course, CTA is going to be much better than coronary calcium scoring. So what's the point? The point is, how do we use coronary calcium scoring? If after quantitative risk assessment of risk, your treatment decision is uncertain, consider calcium score. We use calcium scoring for risk stratification in asymptomatic patients, not for detection of obstructive coronary artery disease. For detection of obstructive coronary artery disease, that's where you use CTA. For risk stratification in asymptomatic patients, that's where you use the coronary calcium score. Okay? Do we have any questions? No? Okay, very good.